Eduardo and Augusto, Paulo, Uranga. And Paulo is going to speak about a very timely topic, as you can see here, inequalities in accessibility to ICU bed across Brazilian municipalities. So Paulo, thank you so much for taking some time for us, and it's all yours.
Thank you. Good morning, good afternoon, perhaps. Thank you for being here. My name is Paulo. My colleague Natasha and Professor Fochesato from PUC also participated in this work. We haven't published it yet. We focus on the spatial inequalities in accessibility to intensive care unit beds, ICU beds, in Brazilian municipalities, how the title suggests. The COVID pandemic has collapsed health systems worldwide, and in Brazil, we observe it in some states like Ceará in the northeast and Amazonas in the north of the country. However, it is a study made in April, before this collapses in Brazil, but we use data from March. The collapse of the health system in Brazil was in the end of April. Our study was made on the first month. In March, we had about 6,000 cases and 200 deaths. So the collapse, we had 85,000 cases and almost 6,000 deaths. Today, we have much more cases and deaths. Almost 5 million cases and more than 104,000 deaths, but no collapse. When the crisis in the health system spread to the major Brazilian centers, the government invested in infrastructure, basically public ICU beds and field hospitals. In Brazil, we have a public health system which serves the most of the population, more than 50% at least. So the number of ICU beds is a very important policy to aim. We could have avoided the rapid increase in the number of the deaths. The student aim, we use the spatial accessibility measure, an indicator of accessibility measure, SAM, considering the population of the Brazil municipalities. The number of the ICU beds in each health institution and the distance of this population to the beds. The inequality was measured using a spatial Gini coefficient and graphical analysis between the population groups and the distance to the beds. And we also discuss the possibility implications in the light of the number of confirmed coronavirus cases and deaths. The data. All the data we download from DataSUS, that database. DataSUS is a very large database who aggregates data from other federal databases. So we have in this database the number of the ICU beds, of course, and the projection of the municipalities' population to 2019, and the geographical coordinates of the health facilities. Unfortunately, only 230 were correct. So we put the addresses of the missing cases on the Quantum TG software, but still 86 coordinates remain missing. For these 86, we search manually on Google Maps. Also, we transformed the coordinates to Universal Mercator Projection, UTM, using the Cirrus 2000 reference system. We use our Central Meridian Zone 22, which covers most Brazilian municipalities. The methodology was based in early work which measured the people accessibility to hospital beds in Greece. All the hospital beds, no only ICU beds. The reference I will show you at the end of this presentation. The SEN calculates the number of beds in each facility divided by the population in the municipality, and the square, the beta here is 2, of the distance between the centroid of the municipality and the health facility. Higher SEN, higher the accessibility. The calculation of the spatial Gini uses the SEN and a matrix of the spatial weights, K neighbors. It's important to observe the decomposition. In blue, we have the Gini of the neighbors, and in red, we have the Gini of the non-neighbors. When the Gini of the neighbors is close to 0, indicates spatial clusters. The third step was the graphical analysis. We separate the population in age and gender groups and compare the distance of these groups to the closest ICU bed. The last step was the comparison of the SEN values map with COVID cases and deaths. The method we used here takes into account 4 important aspects to the theme of accessibility to ICU beds. The spatial location of the beds, of the people, population density, and the physical distance between the people and the beds. Population density plays an important role in identifying where there is a high potential of contagion occurring at greater speed. On the other hand, the number of beds and the distance to the beds allow us to verify in which regions there's a less capacity to deal with a large number of cases. The largest number of ICU beds is on the southeast and the northeast, which are the most populous regions. On the other hand, the demographic density is higher in the south than in the northeast. This statistic is important concerning the need for beds in short term due to the rapid spread of some epidemic disease such as COVID-19. The number of beds per 1,000 inhabitants is much lower in the northern region. Also, this is the region that has fewer beds per 1,000 square kilometers. On the other hand, the southeast and the central west regions have most of beds in private facilities. A large difference in the number of public beds about the total in these regions makes the inequality in the supply of public beds per 1,000 inhabitants the lowest in all the regions, among all the regions. Next. The maps of the Brazilian regions and location of establishments with ICU beds shows the higher concentration on the south in green, the southeast in yellow, and the coastal areas from the northeast region in red. In the interior of the northeast and center-west is in blue, the ICU beds are more distant. The north region has large voids, showing that many locations are unattended. This last region is where located the Amazon forest. Access to health facilities in this region is more complicated because of the difficulties of mobility in this area. In some places, people have to use boats or move through bad roads. The differences in the supply of ICU beds per inhabitant and in the spatial distribution of beds in the regions are signs that there is an unequal access of local populations to the beds. The accessibility of to ICU beds is much higher in the southwest and the south. We can see in the table 2 when compared with north and northeast. The southeast region shows the greatest SEN variability between municipalities, probably because of the density of beds in the metropolitan region of São Paulo. Also, to identify the difference in terms of access between the municipalities, we calculate the SEM logarithm. According, SEM have very high values, no, not so much high values and a lot of low values. That's why we use the logarithm. According to the map, the scores of the accessibility to ICU beds are have higher values in the southeast region, in the north of the south region, and around the federal district in the center of the map, and on the coast of northeast region. These locations in general are closer to major urban conurbations, I think. The northern region has the lowest accessibility to establishments with ICUs. Besides, the south region and the interiors, the countryside of the northeast and central west regions also showed a lower value in the measure of accessibility. I bring here this appendix just to show the spatial Gini coefficient. The spatial Gini coefficient was around 0.7 for the total and public beds, suggesting a severe inequality of spatial accessibility between municipalities. The Gini of neighbors shows a weak spatial correlation of SEN, because we have the Gini of neighbors close to 0, with in the case clusters, spatial clusters, but since for different numbers of close neighbors varied between 0.5 and 0.28, less than 1% of total Gini, it's a weak spatial correlation. Most of the inequality of accessibility is due to non-neighboring municipalities. So probably because Brazil is a very large country and all values were statistically significant. The graphical analysis of the ICU beds by age groups. First, we have to consider that most of the Brazilian population is young. Approximately 50% are aged between 10 and 39 years. The population in the north and northeast are the youngest in Brazil, and the south and southeast have the largest number of elderly people. On the graph, we could observe the cumulative proportions of the populations and see that the youngest are on average further away from both the total and public ICU bed. This is possible due to the greater agglomeration of intensive care units in those regions, in south and in regions with young people, elderly people, sorry, like the South and Southeast that concentrate the largest number of elderly people. In a 50-kilometer radius, the first point on the graphs, 80% of the elderly people would have access to an ICU bed, while for the population up to 20 years old, access would be less than 79%. Elderly people here is people with 60 and more years. If you want to consider the public ICU beds, the access to the elderly population is close to 83% too, while for the population up to 20 years old, it drops to 76%. The age groups at the greatest risk from COVID-19 are those that have the easiest access to beds in Brazil, what is a good thing. However, given the continental dimension of the country, the demographic difference in each region may show a different relationship from the national average regarding the proximity of the beds and the population strata by age group. About the gender, we didn't find significant differences between men and women, and that's why I don't put a graphic here. However, males were found to have a slightly greater difficulty regarding access to ICU beds. It is important to note that in Brazil, men have had a higher mortality rate due to the virus than women. The number of women in total marginally exceeds the number of men too. The North region is the only exception, more men than women. Using the number of deaths as an indicator of where the demand of ICU is highest, since there may be underreporting of coronavirus cases, it is clear that the North region again appears a potential candidate for a health system crisis. What really occurs in Amazonas. It's also evident that this could be also occur in the countryside of some municipalities in the Northeast and Midwest. The Ceará collapse occurred in its capital, Fortaleza, but many people in the countryside search for hospitals in the great cities. Probably this is the Fortaleza case. The data of hospitalizations and deaths from respiratory disease can serve as a proxy for the real stage of contagion and mortality, since many people may have been infected or died without being tested. In particular, the Central West and South regions were more affected by respiratory diseases than by COVID-19. The final remarks when we did the study. Well, the Brazil is a large country. Provide health facilities and ICU beds is a complex task. The inequalities in accessibilities turn the fighting against the coronavirus more difficult. Policies to combat coronavirus have mainly focused on large cities. The problem, however, is not restricted to large urban centers. Accordingly, the results of the study also reveal a worrying situation for the interior of Brazil, the countryside. What happened happened. Many of cities of the countryside of Northeast and North Feds experiment the collapse of the health system, like some cities of Pernambuco. In other regions, some of these kind of cities were close to collapse. The public policy must provide a minimal health infrastructure in the regions with low access. The results allow us to identify which places should be prioritized, that is, those where there is greater inequality of access, especially for the groups at greatest risk. Our next step is to update the data and look where are the fragilities in the access to ICU beds after the late government investments. There are some references in those presentations. The study in Greece is the Kalogeriou 2017, Spatial Inequality in the Accessibility to Hospitals in Greece. You could find in this study the R script, and I put the reference of the package here too. So thank you all.
Okay. Thank you so much for your time and for the presentation. I have a comment and a question for you. So number one, your work actually reminds me a lot of the work of someone called Brigitte Waldorf. She's professor in Purdue. She lives in the state of Indiana, which is close to Illinois. And it turned out that even for the state of Indiana, which is fairly wealthy, the distribution of the population is very sparse also. And she and her colleagues have made some calculations showing you, if you have a stroke, you know, in a case of a stroke, you need to be brought to the hospital within an hour and a half, otherwise you really die. So in a case of a stroke, in some part of the state of Indiana, you could not make it for sure, whereas in some other places closer to the hospital, you could do just fine. So eventually have a look at her work. It's obviously for a slightly different cause. Her case is really about real urgency, whereas yours with COVID, you eventually have a day or two to react. But it's very interesting. You may want to get some nice insight. And if you cannot find her name, send me an email. I will send it to you. The question I have for you is this. So your analysis is great. It's actually really showing you know, the state of the situation. But I think that something you may want to think of is what solutions should be brought. In other words, do you think that the solution is mostly about more hospital in those remote areas? Or is it to try your best to increase the accessibility to large cities through eventually a helicopter or, you know, something very urgent? And as you think about those solutions, you may want to also consider the fact that more and more some rural hospitals are using online technology to actually perform even surgery. In other words, there is someone eventually through Zoom or elsewhere, which is telling a doctor, okay, do this, do that. In other words, little by little, the medical field is going to require less and less actual contact with a real expert. You see what I mean? So is that eventually a possibility that could solve the lack of healthcare accessibility to some rural areas? So there are elements you may want to consider as you move on. Thank you, Paulo. What do you think?
I think that solution using technology to people have contact with a specialist, it's a great idea, but I fear that it works just only on the urban centers, because we have a lot of people, especially on the countryside, who didn't have any access to technology. They didn't have a phone, not even a chance to connect it online to a specialist. So like states like Amazonas, for example, they have a difficult to to arrive in the hospital because of the bad roads, like I told, and sometimes they depends of the took a boat, and it's pretty hard. So it's a solution, but not is an entire solution to Brazil. In some areas, we have really to put some minimal health facility.
Yeah, I agree with you. I guess it depends on how remote is remote, right? I think the solution has to differ by location. Sounds good. I'll send you the contact information of Brigitte Waldorf. Just have a look at what she did on Indiana. Okay, why don't we collect some comments and questions for Paulo? If you have any, just unmute yourself, please, and ask.
Paulo, this is Angie Lyons. And so I found this work really interesting. And the part to me that seemed the most interesting as a development economist was the work that you were trying to do with the Gini coefficient in identifying the inequalities. I unfortunately missed the beginning of your talk because I was at another meeting. So what I was trying to do was to understand when I came in, the data that you have, it's at the regional level or it's at the like how is it at, like how micro is this data that you were calculating those Gini coefficients at?
First, thank you, Angie, for the question. First, we calculate an index, a spatial measurement index, to consider the distance between the people and the ICU beds.
Ah, so you have it at that level of micro data.
Yeah.
So then here is what came to my mind is that really you weren't seeing much difference. You in the change in the Gini when you were looking at, like, I forgot which the comparison was, but it seemed like you were pulling it out at the macro level more when you were showing those Gini coefficients in your table. And so you might really just think about more of the heterogeneities that may not necessarily be spatial, first of all, that I know you were trying to show some of the age differences and things like that, but you might think about some of the other socio-demographics and think maybe there is the Gini effect with some of those other heterogeneities and it's not just geographical. And then the other aspect of it too is that this kind of plays off of something Sandy told you. When you calculate those, like when you're looking at ICU beds, are you dividing then ICU beds by the population of that area? Are you doing that? Because like having like 10 ICU beds in Sao Paulo versus 10 ICU beds in a remote area, that's a very different thing.
Yes, the indicator digits, they divided by the ICU beds by the population.
Ah, okay, so that's already taken into consideration.
We have a problem to get the socioeconomic variables because that database is very restricted. Is not the real number of the population. It's a projection. So they have a projection by age and gender, and
that's it. But maybe trying to tease that part out a little bit more, and via the geographical areas, and this would help to get at what Sandy was also saying is what are the policy implications for this, and maybe where should resources be directed, especially with aging populations. Are there particular areas that have larger, or areas of the cities and things that have larger aging populations and stuff, that if you can see those inequalities and they're growing bigger? I think that was the piece of your work. Bottom line is that was the piece of your work that jumped out as a little bit more interesting than some of the mappings and stuff, which are kind of more standard that we see with a lot of this COVID stuff right now. And I think that part could really, especially from a journal publication standpoint, I think teasing that out and packaging it in a better story, I think is a very fruitful direction to go on, because it's really interesting. I really enjoyed it. So
thank you. I noted.
All right, Angie, thank you so much for the comments. And thank you so much, Paulo, for your presentation. So I think we're going to move on to presentation number 2. It is going to be by Professor Tatiane Menezes. Remind you, I'm sure all of you know Tatiana, of course. She's professor at the University of Pernambuco. And Tatiana, we are ready for you. Nice to see you again. And we are ready for you whenever you are. Yeah, I can see your slides, so you're good to go, Tatiana.
Hi, Sandy. Hi,
Hello, Tatiana.
Thank you for invitation. Okay, our paper is Assessing the Impact of Social Distance on COVID-19 Cases and Death in Brazil, an instrument defense and difference approach. Oh my gosh. Okay. Today, October 2nd, 2020, more than 1 million people had died by COVID-19 in the world, and more than 2,008 in America had died by COVID-19. However, since January 30th, the World Health Organization has been declared that COVID-19 was a public health emergency of international importance. Indeed, no pharmacological action are needed to reduce transmission and slow the spread of disease. Therefore, social isolation is the recommended tool to flatten the curve of case. It was argued that social isolation reduced COVID-19 prevalence, death, and avoid health systems collapse. In spite of WHO recommendation, some country leaders are skeptical about the effectiveness of social distance policy. They argue that social distance aggraves the economic crisis without necessarily alleviating the pandemic. So the objective of our paper is to evaluate the effectiveness of social distance as measured by social isolation index in mitigate COVID-19 cases and death. Here we are working with Brazilian data set from February 1st to May 18th. So we have some identification problems. Indeed, the health contamination increased with the number of infections grow. Therefore, social distance and number of the cases of COVID are simultaneously determined phenomena. Our identification strategy to capture the causal effect of social distance in the COVID-19 pandemic, we adopt a different instrument strategy. Our instrument is the difference estimator built from the interaction between the day that social distance was decreed by the state's governors and state whose government supported the President of Brazil on the date of the grid. Our identification hypothesis is that Brazilian President's speech encouraged Brazilians not to reduce their work activity and thus weakened social isolation at the state level. Such point explain the strong correlation between our instrumental variable and our interesting variable, the social isolation index. On the other hand, the election of President of the Republic would not be correlated with determinants of contamination by COVID-19. So, following the WHO and Brazilian Minister of Health recommendation, most of the Brazilian states decreed social distancing restriction between February 29th and March 29th. Here you can see that before the governor decreed, the social isolation index was around 35%. After the governor's decree, the social isolation increased to around 50%. We are analyze the impact of this shock on COVID-19 cases and deaths. Okay, although the Brazilian Minister of Health recommended social distance, on March 24, the President of Brazil spoke, encouraging his supporters not to follow the restriction of social distance for the states. Indeed, the position of the President contributed to governors who supported him to weaken the social distance decree. Therefore, states whose governors supported the President, the COVID-19 contamination grew faster than other one. Here we can see the contamination rates by COVID-19 in the state that governors support the president, the governor not support the president, and here the states where the governor support presidents. Our variables is our outcome is the case and the death by COVID-19 per 100 inhabitants at state I and day T. Here our interesting variable, the social isolation index. Our instrument, the interaction between both the num that assumes value equal 1 if state I decreed social isolation in day T, and the support, the num that assume value equal 1 if governor of state E support president. Here we have some characteristics, social characteristics, and weather characteristics we are using as a control variables. Here, our model, we are working with a panel data with 27 Brazilian states, including federal district, in 108 days from February 1st to May 18th. Our dependent variable, our the cases and the death by COVID-19, and here our interesting variable. We are working a three-stage least square. At the first stage, we run a diff-diff model, and it's our instrument, the interaction between the day where the government decreed the social distance and dam equal 1 says governor of the state support the president. The second stage, the social index isolation head is put here, and if our identification is hypotheses are correct, it is exogenous. Here's our results. The first stage, the negative and significant results, even we control for all the variables, means that the president speech or president example have negative impact on social isolation. So we can see that the state whose government support the president, the social isolation was smaller than states where the governments don't support the president. At the second stage here, and we can say that both the social isolation index have a negative impact on cases and death for COVID-19. We can interpret these results. You can imagine, hypothetically, if increase the social isolation to 51%, the Brazilian states will have different depend on how far they are from hypothetical index and their population. For example, in São Paulo, the largest and the richest Brazilian state, had an average social index equal to 4.22% between February and May. If its social isolation index had increased on average to 51%, the number of COVID-19 cases would be reduced by 5.57%, and the number of deaths will decrease by 2.4%. It means around 6-7 cases and 2,000 deaths from COVID-19 respectively avoid. Indeed, our results suggest that by increasing the social index by only 11 percentage points in São Paulo state, more than 2,000 lives could be saved between February and May 2020. And analyzing for Brazil, we can say that if Brazilian average social isolation index increased from 39.77% to 51% between February 1st and May 18th, the country would have had around 320,000 fewer cases of COVID-19, and more than 10,000 lives would have been saved. So, some conclusions. The results converge with the literature. The estimated coefficients were consistent and significant, even though controlled by several social characteristics, climate conditions, and information on public health. The estimations show that support for president reduced the magnitude of the social isolation index and then increased the rate of contamination and death by COVID-19. So, we can conclude that not pharmacological action, such as social distancing, are necessary to combat pandemic like COVID-19. Thank you.
Okay, Tatiana, thank you so much for very interesting work, very timely. Actually, maybe in the future, do the same for the US. We need help here also on a very similar question. So let me ask you a question. and some suggestions. Number one, when it comes to the different covariates that you have, do you think it's possible to include some degree of industry specialization of those states? So let me explain to you what I mean by that. It turned out that depending on the kind of work you do, that social distancing become hard or easy. If you mostly work, say, in a services sector, more especially, say, administrative or even, education like us, eventually the social distancing is very easy to put. If, on the other hand, workers are more into meat plant, which has been a huge problem here in the US, obviously the social distancing is very difficult to implement. So one question I have for you, if the data do exist, is it possible to include a bit the economic structure of each state to see if that also could be something to affect basically the final result? The second question I have for you is this. For the US, it may happen that a state, let's say, is Republican, but the largest city in that state is actually Democrat. In other words, some cities are not necessarily aligned with the state. Is it the same in Brazil? Your analysis is obviously at the state level. So could it be that the governor of the state say, we go in one direction, whereas some cities within the state say, I'm sorry, I don't agree with the governor. For my city, I'm gonna instead do this. And if that's the case, is it possible to include a bit of a different strategy between what the state is doing versus what some of the cities within the state are doing? Do you think it's something of interest for the Brazilian case?
Okay, first of all, our data set is daily. So we don't have this kind of information, industry information daily. So you can't. I think the more interesting thing is that we are working with data sets.
Okay.
And the second one, it's in our work, in our paper, we are working just with state data set. We don't have exact municipality data sets, and what we can really say is that we have some states that the governors support the president, and the other one that governors don't support president. And in the case where the governors support the president, the COVID grows fast.
Okay.
So I don't know if you can think about different kind of strategy. I think I don't know. I'm not able to answer this question. Okay. What I can say is that I use this difference to identification strategy to answer the question. Social isolation is matter, and we answer in our answer is that yes, it's matter. So when we use the identification strategy, the results is that.
Yeah. Now I see it. Your results, the marginal effects are indeed negative and highly significant.
Yeah, exactly.
Very good. Let's take a few more questions and comments for Tatiane, please.
Hello, Tatiane. How are you?
How are you?
Thank you for your presentation. I don't have any question. I just have some students working on this term, on this subject. Yeah, I'd like to know the reference of your work, if it's possible. If you can send to me in the chat, I appreciate it very, very much.
Actually, I have a working paper, and I can send it for you.
Oh, okay, thank you very much, Tatiane. Nice to see you.
Thank you. Nice to see you again.
one little additional question, Tatiane. Did you have fixed effect by state in either stage 1 or stage 2? I did not catch that.
Yes, I have. I just actually, the characteristic information don't change in time. It's just change by stage. So it's like a fixed effect.
Okay, but did you try the equation with actual fixed effect and eventually not having access to those wages or employed characteristics, just to verify if at the end the marginal effect of SSI is the same with state fixed effect versus including those covariates?
No, I didn't change this variable, but I think it's a good idea. I will try to do that.
I will say as
if the results change. I didn't
as a robustness check, and if you
yeah,
do
sure.
If you do that, it will also account for the comment I had earlier, because you know that economic structure doesn't change over a short period like this. So it will be totally absorbed by the state fixed effect. So it's very interesting. Okay,
Sure.
well, I think we're going to leave it to that. So thank you so much, Tatiane. Thank you so much again, Paulo, for very interesting and very timely presentation. We definitely need a lot more research on the terrible pandemic we're going through now. And then with that, I'm going to let you go and see all of you next week in the same location and at the same time. Thank you so much again. See you.
Thank you.
Bye-bye.
Bye-bye.
Thank you.